Hello everyone, and welcome to Restorative Health Solutions. If you understand what's making you sick, then you can start to understand how to get better. More information is power. Hello, I'm Dr. Warren. I recently had a patient come in who was very, very frustrated with rheumatology and with her experience kind of bouncing through the medical system, and they couldn't find what was wrong with her, and it was really Lyme. And I just want to talk about this in case this is happening to you. I think this is the most common place that Lyme people end up. It's probably close between the neurologist and the rheumatologist, but one of my big problems with this disease is just how it's missed on so many levels. And unfortunately, because it causes so much pain, we get into rheumatology pretty quick. So I'm going to go through this article, but I will also quote some of this CDC stuff. So, when we're looking at, this is just the CDC website, there's a treatment section for Lyme, and it's very obvious there's a Lyme arthritis. And what I will say is Lyme was actually discovered as Lyme arthritis before we realized it caused neurological problems as well. We recognized it caused pain, headaches, neck pain, joint pain. Loves the knees. You'll see pictures of knees right here. So for many, many people, Lyme disease looks like some kind of a pain syndrome. So you're going to get sent to rheumatology for a lot of inflammatory arthritises, and they're going to check you for lupus or rheumatoid arthritis or mixed connective tissue or these kind of autoimmune inflammatory conditions. What I want to highlight is just the odds of you having any of these autoimmune diseases at a rheumatology appointment are statistically higher if you are a female than a male. When we're starting to have doctors go, maybe this is rheumatoid arthritis, maybe this is lupus, we should at least know that, Lyme is in the differential diagnosis. And then we ask, are you in a Lyme endemic state? Are you in a place like Minnesota or Wisconsin that's very common to have Lyme disease? The other question you should ask is, are you a guy? Because all the autoimmune, rheumatology, and lupus things are more common in women. And so women can get Lyme disease also, and men can get Lyme disease. But statistically, if you're going to line up what looks like rheumatoid arthritis in a bunch of women, you're going to have more of them actually come out rheumatoid arthritis. And if you have men, you'll have less of them come out rheumatoid arthritis, just statistically. I see more men than I used to now that I see so much Lyme disease than when I did many other conditions, which are just statistically more dominated by females, such as rheumatoid arthritis, such as lupus. So when we're in a Lyme endemic state, we're concerned about Lyme, particularly if the arthritis kind of seem to come quickly out of nowhere. That kind of screams infection. And we can just see here there is this obvious reliance that Lyme causes pain. Now, according to the CDC, if they diagnose Lyme, and we'll get into some of the problems with diagnosing it, but they're supposed to do doxycycline 100 milligrams twice a day for 28 days. And this is, for the rash, they really should do 10 to 14 days. And when we have the arthritis involved, they recommend a longer course. Your doctor can do this course about 2 times before the system will flag them and really block them from doing anything farther. After, if this does not work, they will just give you meds for your symptoms. That's what they recommend. So they'll just give you pain meds and prednisone shots and all these kind of things, right? Cortisone shots. Send you to PT for pain, send you to pain management. So they really can do this treatment about twice. But let's talk about this is if they find it, this is what they're supposed to do. I think this is not a great standard, but most people don't even get, this standard. Let's run through this other rheumatology article and just go, why does the doctor miss you in the first place? Because that's mainly what I see. I do see people who've done antibiotics and failed, but I have a good amount of people, including the person who came to me Monday, who was just so frustrated that no one can find the problem, and we were able to find it fairly easily. So, article, what rheumatologists need to know about Lyme disease and tick-borne illnesses. And they're interviewing John Alcott, who is one of the researchers out of Johns Hopkins, brilliant doctor, really been pushing that this causes problems. And the Lyme disease people are ending up in the rheumatology section. Once again, we've got about 450,000 cases a year of Lyme, 500,000, 450,000. We got about 50,000 in Minnesota, 50,000 in Wisconsin a year. Early Lyme disease isn't what we argue about, but just note it can cause fever, headache, fatigue, and rashes, and then also can cause neurological symptoms. There's just this obvious recognition that now you have weird nerve things happening, weird brain things happening. Lyme is certainly plausible. So remember, although we're talking about rheumatology, there's also a certain amount if you're going to psychiatry or neurology, it can be Lyme, and I never see a neurologist who's checking for it or even thinking about it, and I rarely see a psychiatrist who's checking for it or looking for it. The other part here they say is untreated late Lyme disease arthritis can develop months or years after the infection. So there is right away this thing of, oh, this can become an inflammatory arthritis. If I kind of go down late Lyme disease arthritis, if we're missing the diagnosis and the treatment, they think it's 60% of people developing late Lyme disease. That's actually the highest number I've ever seen. They do quote some other research where they think the fail rate is 10 to 20%. I think that's probably, I think 20% fail rate's probably little more. Now they're saying 10 to 20% of people who get antibiotics are failing. I do understand that. I don't know and did not go pull this research. Maybe I will. They're saying 60% of people who aren't treated, meaning if you don't get antibiotics or don't get anything, will develop into late. I've seen very little data on people who just aren't treated, period, and I don't know where they're getting that. So that seems very high, just so you know. Everything I've done is about 20% fail rate. Now, they're using this two-tiered testing, and we talk about this other places. This is a testing protocol from the mid-90s. I really don't like this protocol. It has great sensitivity, which you're going to see right here. Two-tiered testing for Lyme disease arthritis is very high, 97%. The sensitivity. Now, for those doctorates, you learn this at some point in time in science class. Sensitive means if it's positive, can we trust the positive? Meaning, are there false positives? And the answer is there's very, very few false positives with this criteria. Now, the problem is the specificity is really bad. So there's tons of false negatives, and that's the issue. You go to the doctor, they run this testing, and they go, well, it's sensitive. I go, right, that means you can trust a positive, but it means you can't trust a negative. And that's a huge, huge problem. And we talk about this in other videos, but you really need to be running multiple species of Lyme at this point. I don't think the screener test is worth it. It's developed off an HIV model where the screener test is super great in HIV. The screener test is definitely trickable. In this case, we had somebody who was positive on the screener test and didn't quite hit all the criteria on the follow-up blot. I think that's Lyme unless you have a better explanation. They didn't have a better explanation. So we start going, you're supposed to be coupling the test, the evidence, with the symptoms to come up with the most likely scenario for the patient. This is not done. This is really just lazy doctoring. What practically happens is doctors just run the test and don't do anything if it's not straight up positive, which is not recommended by anyone anywhere, like under any written condition. The doctor's supposed to take the evidence, your history, your symptoms, all the tests together and make a clinical choice of really what's happening to you. Practically, we see that just gets a little lazy and they just go, if the test is negative, it's negative, it's positive, it's positive. This is where we go. Initial treatment is 30-day course of oral doxycycline, 28 days, 30 days. They're kind of rounding here, but I think that's fine. That's kind of the standard treatment. Now, I don't think that's a great standard, but most people don't even get that because doctors are kind of moving too fast. Treatment of late Lyme disease arthritis is 90% effective. 10% of patients develop post-infectious antibiotic refractory Lyme arthritis. I'm not sure where they're getting that it's 90% effective, not exactly when. There's a nice study that came out of Tulane. This is December of 2023, super recent. In this study, they gave a bunch of mice Lyme and they do the antibiotic therapy and they wait 60 days in between getting the Lyme and the antibiotic therapy. And by waiting 60 days, the single therapy with this doxycycline doesn't work anymore. So in the initial month, a lot of studies, they wait 30 days and then give the antibiotics. It seems to work 80 to 90% of the time. If you wait 2 months, the fail rate's huge. And what Tulane found is they had to hit it with more antibiotics and multiple antibiotics in order to get it better. So this is not the first study that's found if you get the antibiotics really quick, they work well. One of the first ones I've found that if it's 60 days, it's not going to work well. You're going to have to do more, right? Now we can talk about what more is, right? I think it's very possible to do high, heavy antibiotic protocols. but doing multiple antibiotics is hard on you, particularly you have to do them a long time. And there's many people who would say, look, they did 3 antibiotics for 6 months, 12 months, 24 months. And while that can, it is a way to go about, it's certainly a way with some downside in a way that I'm not the biggest fan of. Let's just keep going through this. So there is a post-infectic antibiotic. There's a post-treatment Lyme disease syndrome. Once again, this is all acknowledged that it exists. And there's a 10 to 20%. Here's this. We've quoted this study before. There's a 10 to 20% of patients who develop chronic Lyme, or what's now called post-treatment Lyme disease. What's hard for me when I have a rheumatology appointment, or when this particular patient was telling me the story, the doctor said there is no chance this is Lyme disease, period, based on the testing. Even though the screener test was positive and there was some mixed stuff on the follow-up test. And all the rheumatoid arthritis tests were negative, and they have tons of symptoms. They have knee pain, they have this arthritis pain, they live in Minnesota. Literally, it happened in the middle of the summer after a camping trip. And so I looked at it and said, I'm so sorry, because it's not hard to find that the testing isn't perfect and that this stuff happens and there's a 10 to 20% fail rate. And the patient went home very frustrated with the rheumatologist and was able to quickly just pull research and go, you can't tell me it's 100% not on the table and that it's not possible, especially if you don't have a better explanation. And this is actually something that I get into with a lot of doctors. And I think some doctors will say, no, it's not this, go away, it's not my thing. But at some point, there is a reason for your symptoms. There can't be no reason. That's not the way the world works. And too often, they'll say things like, well, it's not Lyme, and they're just not well educated on all the holes and the modern research and what Lyme kind of is. But they don't have a better explanation. And so it's one thing if you're like, look, all your RA tests are positive. It's rheumatoid arthritis. It's not Lyme. It's another thing when you have test after test after test after test saying, it's not that, it's not that, it's not that, it's not that. And I'm going, okay, what's your most probable cause? And we know that there's a hole in it. We need better, more updated testing than this standard. And we know a 10 to 20% fail rate. Guys, 10 to 20% is a huge amount of people. There's close to 500,000 people getting Lyme every year, and there's a 20% fail rate. I mean, that's 100,000 Americans every year that are ping-ponging through the system and they can't figure out what it is. That's a huge number. You know, just in Minnesota, it's probably 10,000 every year, this year, next year, and they're just, the people are stacking. And so, you know, it's a major problem, and I think rheumatologists are seeing it routinely. I mean, one of the questions I asked rheumatology is, how many times last year did you diagnose Lyme? The answer should not be 0. It absolutely should not be 0. A certain amount of people who are walking in with what looks like rheumatoid arthritis to most doctors is in reality Lyme disease. The sad part is they're generally missing it, and the antibiotics work well right away, but we have research going, if you're missing, the antibiotics aren't applied by about 60 days, the success rate's plummeting, and you're going to need to do something definitely more aggressive. I think going more holistic is the best way to do it with the least amount of side effects. We have other articles where we talk about that. But I just wanted to highlight today that it's really not hard to find that rheumatologists need more education on that they're getting Lyme patients thrown in their lap because it mimics and looks like an inflammatory arthritis or a lupus or a rheumatoid arthritis. But if it looks like that and your arthritis tests are negative, then there's a strong possibility you're really fighting Lyme, and you need to find someone who knows how to deal with Lyme in order to get better. You have to aim at the root cause of your problem to get a long-term solution. Just covering up inflammatory symptoms is a bad choice, because if you miss the root cause, it'll keep driving the problem. I, for better or worse, am obsessed with finding the root cause problem and really dealing with that. It's not evil to help symptoms, but it is dangerous to help symptoms if you don't know what's really causing them. And that's where I really got into accurate testing to help find a better long-term solution so you can be healthy and go live your life. I'm Dr. Warren. I hope you found this helpful.